Okay, good morning. I'm aware that we are a bit short on time and that keeping people regularly caffeinated at these types of events is quite important. So what I'm going to do is actually skip through a lot of the slides because very reassuringly, I think there were some really sort of key common themes, and I was trying to make some notes down as we went through the previous presentations of sort of gaps that I could fill, and Connor just wiped out a couple of the last ones that I managed to find. But hopefully what I'll do is I'll give you a bit of background about what we've been doing in Northwest London, and then I'll just skip through and just kind of talk through some of the key thoughts really that are starting to emerge as we move into an implementation phase. So just so that you've got a bit of background, that is Northwest London. So it's 2 million people, it's 8 boroughs, 8 CCGs, which are broadly coterminous with the boroughs. We have over £4 billion of annual health and care spend, over 400 GP practices, and there's a lot of kind of variety within the population, within the ways in which care is delivered and planned across all of those patches. We've got 10 acute specialist hospitals, 2 mental health trusts, 2 community health trusts, one of which is HRCH. So moving forward back a couple of years ago now, 2013, leaders from across all of those different organisations came together and really signed up to this vision. We put in an application to be one of the integrated care pioneers, which some of you in the room might be part of organisations that are pioneers. I don't think anyone would necessarily disagree with anything that's up on the slide, and I think it probably resonates with a lot of other vision statements that are out there around integrated care. So really critically, number one, people being empowered to manage and direct their own care. And I think that is one of our real challenges in both health and social care, is how do we change the ways of working and change the ways that teams function around people to support people and empower people to be able to feel that they can do that and take control of their own health and well-being. Our second principle, and I always slightly change the voiceover of this, I think it really is primary care is at the centre of organising and coordinating people's care. And the reason for that, and that was one that we had quite a lot of conversations about, is that primary care is the bit of the system at the moment that has that picture of someone as the whole person. Looking at the kind of cradle to grave type model, people who are family practitioners, primary care is the bit where the information, the repository, the registered list sits, and it's where the sort of interaction between clinician and whether that's a nurse or a GP, healthcare assistant, and even the kind of the front desk, the receptionist, is often about the person as a whole. And that's the model that we want to try and get to in terms of addressing a lot of the challenges that we have in the system. And number 3, our systems will enable, not hinder, the provision of care. So that really comes back to a lot of the underpinning ways of working that we have at the moment. Often sort of materialises in obviously things like informatics, and I can talk at length, as I'm sure lots of people in the room can, about the challenges that we faced about trying to join up information, so that actually when someone comes into contact with an individual, they're not just working off that one individual contact, they've got some level of history and information that supports the way that they interact with that individual and the way that they then decide to take that individual's care forward. And equally, things like contracting, finance approaches. At the moment, the way that all of that is arranged actually leads to the fragmentation. You've got organisations being contracted in very different ways, being managed on service level agreements, and that doesn't really help us put the person at the centre. If you want to put the person at the centre, actually, we need to think about the outcomes that matter to the person. I'll move on to that in a second. This slide, just very quickly, really, I was just going to talk a little bit about the leadership point that I think a few people have mentioned. If we want to be able to deliver truly integrated care, it needs a different style of leadership, and it needs leaders across local authorities, across provider trusts, across CCGs, across primary care, to come together and start to address that question that Connor just flagged at the end there, which is, so if there is a deficit, whose deficit has it? Actually, it's the system's deficit, and when we talk about NHS being ring-fenced and that spend being protected, we know that that's not true when local authority budgets are being cut, because actually the demand and the challenge that we're going to face in the health service will come from that. So Leeds, I'm sure people will have come across this. Leeds have a really great saying, which is the Leeds pound, which says there is only one place that £1 can be spent in Leeds. It's all of our resource, and we need to make sure that it's spent well. And I think similarly, that really applies to how we're trying to work in North West London. Actually, the resource that we have in the system is the system's resource, and we need to try and make best use of it. And to get to that place takes actually a lot of work with sort of leaders in the system, because that's not the way that we either have traditionally worked necessarily, or the way in which the regulators want us to work, because there's a big shift now that we need to think about in terms of how our systems and organisations are regulated, and kind of moving those national bodies forward is as much of a challenge. And the leadership, the sort of systems leadership that we need also, as Conor mentioned, is all the way through the system. So this isn't just about how chief execs sit around a table, it's about how heads of services talk to each other, it's about how the frontline staff, and there's a lot about role modelling in there and how we start to project an image of ourselves as public sector leaders, which then resonates all the way through the workforce. Just a really quick mention here. So one of our key principles was around co-design. So when we started to address what integrated care might look like in North West London, we put service users and carers into that conversation, and not just service users and carers, lack of caffeine, but also frontline staff. So a really key bit about this is how bringing staff on the journey, actually this is, as much as this is about empowering service users and carers, it's also about empowering staff to address some of the challenges that they see on a day-to-day basis. And it's a chance for them to actually contribute and shape the way that services are delivered. We can go through, I mean, you know, my team's called Strategy and Transformation. You can think about strategy till the cows come home, but actually, if you put a district nurse in the same room as a GP practice manager, and they can sort out a lot of the problems around the communication, and actually just having those conversations was really powerful. And having service users and carers in there was really critical, because it meant that we could have a conversation about respect across teams, and the respect across teams equally applies to respect to service users and carers. So it really was a kind of a leveller in terms of those conversations and what everyone had to bring to the table. This is just really quickly, so we're trying to move towards outcomes-based commissioning, and these are some of the outcomes that came from the work that we did with users and carers. My favourite one on this actually is the bit about the common simple language, because again, as much as that matters to service users and carers, it really matters to staff, because every staff group had a different way of explaining something around care planning or the way that they worked, and often they either thought they were talking about the same thing, and actually they were talking about completely different things, or they were talking about the different things, and it turned out that they were actually all trying to deliver the same thing. So that bit about language is really important, and it's, I think, often kind of really overlooked. Those are our outcomes domains. They're in the slides. You can have a look at that. And then moving forward, we've gone from this kind of design process and into implementation, and we've started implementation at local level, really so that we can start to build those relationships around place and local systems, with the view to then implementation being sort of that much more robustly hooked onto that local leadership in each of our different areas of North West London. This is just an example of one of the models of care that's been co-designed by staff and service users. I won't go through it, but it's just an example of all the different bits and pieces, and it looks pretty complicated, but when you actually apply some of the simplistic principles we've got to it, it kind of follows all of the principles around having the person at the centre and kind of thinking through how we might organise our teams differently. And this is just about saying, coming back to the point that was made about timing, we don't really have the luxury of time now. We've been talking about this for a couple of years, and it does take time. It takes time to form those relationships. It takes time to get everyone coalesced around a common vision. And we're now looking at the next 2 to 3 years to actually get these new models of care, new models of governance up and running in North West London. So getting the basics right, that was really about saying, actually, sometimes integrated care and you know, there's always a temptation to bring in new competency frameworks, new ways of working. Actually, we can't deliver excellent integrated care without delivering excellent basic care. And just getting some of that stuff right and making sure that the workforce is supported and able to do that is really critical. And addressing challenges like reducing variation, we mustn't forget that we need to get the basics right in our move to doing all the kind of other complex and kind of innovative stuff on top. Real world planning, I think what that was about is kind of working with what we've got, and similarly to Patricia, the phrase care navigator slightly makes my blood run cold, because it feels like what it's doing is placing another layer of people in the system to try and navigate the system for people, as opposed to sorting the system out and making that a core competency of what everyone's doing. So starting with the staff that we have, we've got fantastic staff, I think it's really a plea around thinking through how can we work with the staff we've got and empower those staff to be able to sort of work in the new ways rather than thinking about new models and kind of new paradigms of care. Harnessing primary care. So as I mentioned, one of our core principles is about primary care being at the centre, and that's quite a challenge. I think there was one GP. Was there a GP Federation person in the room? But I think by and large, the people in the room are from the trusts and that is and kind of CCGs. Actually, a huge amount of the workforce we need to deliver these models of care is sitting in primary care. And prior to the Health and Social Care Act, we sort of had a mechanism to sort of support that workforce. And in a lot of areas, that infrastructure got stripped out a few years ago. And it's a really critical bit of the picture. So harnessing primary care is really critical. Empowering people, that goes back to the leadership point, and that's not just about staff, it's about service users and carers. And redefining the team. Again, if we're going to put people at the centre of their care, we need to think about how they are part of the team and take out some of the sort of slightly artificial boundaries we have. The stats around the unpaid hours of work that carers put in to making sure that people are sort of well and safe in their own homes is staggering. And it feels like, again, a resource and a part of the system that we really need to think differently about if we're going to create a system that's sustainable going forwards. So I think that was me. Okay, thank you.